Hello, Web Shadowers. Thank you all for attending today. For those of you who are new or who haven't attended this semester yet, we've updated our guidelines a little bit, so you will now have to sign into a Google account to fill out the Google Forms. This means if you don't already have a Google account, please make one soon. They're very quick and easy to make. Attending today.
Along with requiring sign-ins, we have added one more question to the Google Forms, making it a total of 4 questions and a summary. So please at least earn a 75% for us to receive verification of your attendance. And also, please remember to make your summary at least 3 sentences long.
And as always, please remember that the Google form will be posted in the chat box at the end, and it'll also be in the description of this video.
Now, with that all being said, today we have the pleasure of hosting Dr. Reilly, who will be teaching us about emergency medicine. Dr. Reilly, you may start whenever you're ready.
All right. So I'm looking on your page. I'm trying to find the, there it is. Got it. Just, old man syndrome over here. Can't figure out technology. All right. Hi, everybody. Welcome to my shadowing session with Web Shadowers. It's good to see so many people in the chat. We're going to try to answer questions at the end. I am doing a little bit of an overview of a trauma case. But first, I'm going to talk a little bit about emergency medicine, what it is, why I got into it, my personal journey, and everything else that goes along with it. So without further ado, that's me, Dr. Reilly. Let's go. So who am I? So I'm actually a first-year emergency medicine resident down in Tampa Bay area at Brandon Regional Hospital. We're associated with University of South Florida. And, this has been a dream of mine ever since high school, to be an emergency medicine physician and a doctor in general. Actually, I grew up in Hillsborough, New Jersey. If anybody from New Jersey is on the chat, go Jersey. But Hillsborough, New Jersey. And from there, I went to Johns Hopkins University, where I got a Bachelor of Arts in biology. At Hopkins, I was actually a pitcher on the baseball team. I miss those days so much. Miss the guys and all the, amazing teammate experiences we had, and just amazing times of college. I also did some research at the Brain Science Institute at Hopkins on ALS, which was very gratifying and extremely interesting. After I graduated from Hopkins, I did a post-bac and a postgraduate degree, my master's in science and biomedical sciences at Drexel University in Philly. And so the reason why I did that was because I realized I had to take a gap year, and baseball took up a lot of my time in college. And I went to a pretty competitive school where I didn't really have that much faith in myself. And I kind of thought of myself as less than a lot of my classmates. I was going to school with kids that were inventing, had patents on, some incredible cancer drug or whatever. And, I was just a baseball player at Hopkins, and I was just trying to get by. And I thought that was the wrong mentality from my younger years. So I took a couple of years off in between my studies. And eventually, after Drexel, getting my master's there, I applied to med school twice, didn't get in. At that point, I was just, beside myself, but I think that made the passion burn that much more and made me want it that much more. So I actually talked to a family friend of mine who is an emergency medicine physician who graduated from St. George's University, which is a Caribbean medical school. And I talked to him for a while, learned about it. I had no idea what it was at the time. And he opened my eyes to a whole new opportunity. And I took that chance, flew down to Grenada. You do 2 years down there and then 2 years of your clinical rotations in the United States, which I did at Hackensack University Medical Center in North Jersey, as well as a multitude of other hospitals in New York City and New Jersey and Miami as well. At St. George's, I was magna cum laude, And I really worked my butt off because I knew I was taking a huge risk by going to a Caribbean medical school. But I knew that the only thing they were doing was giving me the opportunity to get my MD. And I took that opportunity. And here I am now. I matched into emergency medicine, which I'm super pumped about. And I'll, tell you guys a little bit more about that. But some of my hobbies include music. I like to play guitar, sing, write and record my own stuff. Back in med school, this is me and my buddy right here. We would play a lot of live music shows. So much fun. Another is working out, obviously, golf, basketball, baseball, any kind of sport. Love playing it. And I actually started a podcast with my good friend and colleague, Dr. Alex Schuper, who's actually the speaker for tomorrow's session. And you can find that on Apple Podcasts if you guys want to listen. It's pre-med advice, med student advice, applying to residency advice, and just, general information about medicine, our specialties and other specialties. And yeah, that's been going really well. So that's a little bit about me. Emergency medicine. I found this the other day. I thought it was really great. What we all have is the inner drive to go towards danger, not away from it, to treat each and every person, regardless of race and gender or anything else, as a person who we can help. When we do, they may turn around at the end of the day and say, what was that doctor's name again? And it doesn't matter. They know we were emergency physicians. They know that we were the best thing that they saw on their worst day. And that's what makes emergency medicine special. And I want to let you guys know there are plenty of times where I introduce myself several times to a patient and they will not remember my name. And that's because these are brief interactions you're having with these people. You're not their primary care doctor. And that's a skill that you have to learn in emergency medicine, how to establish rapport with that patient. So this is what emergency medicine can look like. You walk into the room, patient's vital signs are completely normal. Maybe they have a little bit of a bellyache. You do their labs, everything comes back normal, and you give them the reassurance and you say, we don't think anything's going wrong with you right now. We're glad you came in. It was probably the right call because you were, experiencing these symptoms. You were nervous, came in, and go follow up with your primary care. The patient's happy, right? Or you could have this. This is a trauma scenario where you work with your trauma team for whatever comes through those doors. It could be, multiple gunshot wound. Last week, a couple of co-residents of mine were in on a multiple gunshot wound case, which was extremely intense. But in those moments, you stay calm, you stay cool, you stay collected. And there's a stepwise approach to approach trauma. And honestly, after a while, trauma just becomes very repetitive because you're doing the same thing over and over again. Your ABCs, which I'll get to. Another cool thing about emergency medicine is you get to know how to do these. These are EKGs. This is the electrical activity in your heart. And these are different leads placed on your chest that correlate to areas of the heart where electrical activity flows through. And if you showed me this when I was a pre-med, I would have been like, what the heck is that? How the heck do I interpret that? But now that I'm a resident and I see them constantly every day, these are things that I've gotten a little bit more comfortable with. And by the end of my residency, which mine is actually a 3-year residency, I should be pretty proficient at it. Another reason why emergency medicine's awesome. Procedures. So many procedures. Actually, a lot of people who apply to general surgery end up applying to emergency medicine as well because of all the procedures that you can get. So in emergency medicine, you need to know how to do all of these things. You need to know how to get, line access with central lines or PICC lines or femoral lines right in the middle here. If you need pressors for the patient or, to control their blood pressure in a crashing patient scenario, you need to know how to put in a chest tube. If a patient's lung collapses, you need to know how to reestablish that lung volume and create access to the thoracic cavity. You need to know how to, do a pericardiocentesis, which is where you take a long needle, stick it into the sac surrounding the heart, and draw out fluid in the area that's causing compression of the heart. You need to know how to do a lumbar puncture to diagnose meningitis, or, get rid of some of the increased intracerebral pressure, which Dr. Schuper will definitely be talking about tomorrow. And then right now I'm actually on my anesthesia rotation, and we're becoming masters of the airway. When someone needs to be intubated, they can't breathe on their own, or they have decreased mentation. This is what you do. You have to take their airway. You have to put them on a breathing machine and let the machine do the breathing for them. And then this is, just our ACLS algorithm, CPR, shockable rhythm versus not shockable. These are all things that are way beyond the scope of what we're going to talk about today. But again, procedures, why I love it. And let's talk about it. So the patients that come in, they're undifferentiated. We're the first line of defense. Whoever comes in through those doors, we're going to see, and we are the first to assess those patients. We have to say, are they sick or are they not sick, right? We always need to consider the worst possible diagnosis for any given chief complaint. While also, we try to figure out what's the most probable in this case, or, what's uncommon. What is a rare case that we may be seeing right now, a rare presentation that we may be seeing right now. So you have to think about all these different possible diagnoses in your head while talking to the patient, gathering your history, your physical exam, and going from there with your labs and imaging. As I talked about before, the quick rapport is so important. You don't know these people. They have primary care docs, or they may not have primary care docs. You have to rapidly establish trust with the patients, their families, and this is their most vulnerable and, biggest times of uncertainty in their life. They could be scared to death, or a family member may be scared to death. You don't know how they're going to react in these situations. And just remember the quote, people don't care how much you know until they know how much you care. And you are truly the calm in their storm at that point. Now there's critical decision-making. Because of the acuity of the emergency department, you need to make decisions fast. And if you don't, someone could die. And that's a lot of pressure. And it takes someone to be calm and cool in these situations and quick on your feet and making decisions quickly. And in medicine and in life in general, no one is perfect. Everyone makes mistakes. So when you make these quick decisions, sometimes they may not be the right decision, but the whole point of training and the whole point of practicing is to make sure that you do make the right decision the majority of the time and almost get that reflex. Multitasking. It's called distraction decision-making in emergency medicine. You're running from room to room. This patient's got cholecystitis. They're going to surgery. This patient just came in. They got hit by a car. They have a couple fractures. Let's reduce the fracture. Oh, wait, the patient in this room's coding over here. Dr. Reilly, this patient's septic down the hallway. So it's like, constant attention being brought to different areas, but you need to remember to find a way to bring everything back and understand where you are and how to approach each patient. Teamwork. I talked about baseball before. I have an extensive background in teamwork, and I love the teamwork atmosphere in the emergency department. And being an ER doc, your character is to become the cornerstone of your ability to be the leader of the team. You establish roles. Everybody feeds off of each other, their energy, their emotions. If you're calm, everybody else is calm. If you're nervous, everybody else is nervous. So that's the most important thing, is staying calm and cool and collected. Procedures, I explained them before. There's a ton of procedures, almost mini surgeries. Safety net. We are the safety net of the medical world. No patient is too poor, too non-compliant with medications, or seeing doctors, too old, too young, or too pregnant to be seen in the ED. We see everybody. We don't care if you're homeless, you're a drug addict, whatever. We have to see you, and we will see you. Next is that ever-changing field. Every day is different and unpredictable. And it's really important that you keep up with current practice in emergency medicine. And something that's really cool is you have a work-life balance. You're only at the hospital for a fixed amount of time, but while you're there, you're working really hard. Sometimes some docs don't even go to the bathroom when they're on shift. Some barely find the time to drink water or even go get food for a break. And these shifts vary from, 9 to 12-hour shifts. But the good thing is after that, you go home and spend time doing other things you love, spend time outside the hospital. These shifts vary in length, but you need to realize you're working days, nights, weekends, holidays. Another cool thing is you're not really on call ever, which is nice. And that's that. So these are the challenges in emergency medicine. You're going to see some things that are going to scar you. You're going to have some very emotional experiences. You're going to get emotionally attached to some patients, and people are going to die on you, and they're going to die on you unexpectedly and suddenly. And that's something I've already in med school. I already had a patient like that where it, was an emotional connection. You're going to have somebody who reminds you of somebody in your family. The only thing you can do is try to be as empathetic as possible and try not to get too attached, because if you get too attached, then that's when you go down the wormhole, and it can really affect your job performance and your integrity as a professional. Another thing that kind of stinks is in medicine, we're going more towards metrics and patient satisfaction being a factor in our reimbursement as doctors. If a patient's not satisfied with their visit, they'll tell you in a survey they're not satisfied. Then you don't get paid the amount that you should have gotten paid. And a lot of physicians argue, well, that's kind of not fair because, all ERs have long wait times and, they're sick to begin with. So no one would want to be in the ER. So that's definitely a challenge as well, but we try to do the best we can with the metrics and patient satisfaction. You also mess up your circadian rhythm. You are sometimes switching from days to nights. In residency, when you're scheduled for a month, they try to switch you from days to nights maybe once or twice in the month. They try not to do more than once, and just keep you on a string of nights for 5 days in a row. So for my program, we do 7 to 7s. So at 7 a.m. you go in, 7 p.m. you leave, or 7 p.m. you go in and 7 a.m. you leave. And they try to get everybody on top of the same schedule and not switch back and forth too much. And then there's this thing called burnout. Burnout is a huge topic in emergency medicine. So burnout's actually an erosion within 3 critical areas. You have engagement, emotions, and an erosion of fit. So the erosion of engagement involves decreased energy and enthusiasm for medical practice in general, which I see on the daily from not only emergency medicine physicians, but other, physicians in the hospital. Another one's emotional erosion to cynicism and bitterness. You'll see a lot of cynical docs saying things that they shouldn't be saying. I don't see this specifically at my program, but I know as a scribe, I would see it from time to time. And finally, the erosion of fit, which involves feelings of discomfort and a sense of isolation. You feel like you're alone. You feel like you can't really talk to anybody. So when you're feeling this burnout, you have to address it. You have to realize you're having burnout. You have to address it. Go to leadership, talk to people in your program or talk to other emergency medicine physicians and try to figure out how you can fix that. And yeah, so that's burnout, which EM actually has one of the highest rates of, actually the highest rate of burnout in medicine. But if you recognize it early and combat it, you should be fine. So post-residency, after residency, you can just be an emergency medicine doctor, which is what a lot of docs do, or you can go into all of these things. There's so many fellowships and things you can do, like wilderness medicine or hyperbaric undersea medicine, or you could go to administrative or health policy, go the political route. So there's a lot of different opportunities for emergency medicine physicians out there. And remember, guys, no path is right. I know you're all pre-medical students, and you all feel, bogged down with work, and you feel like sometimes you're not good enough. But remember that there is no one correct path. And that's something I realized after, becoming a doctor is that everyone has their own path, and you should keep your blinders on and don't pay attention to people who have a certain path that you don't. Something I got bogged down with was, I always thought it was high school, college, med school. No, it's okay to take gap years. The biggest thing with a gap year is know why you're taking it, and you have to improve something on your resume. That's the point of the gap year, to show these people that you improved upon yourself, your knowledge, your GPA, whatever it is. So in my gap years, I did my master's program. So I got more classes, more experience that way. And then I was also a scribe in the emergency department, which was actually my first exposure to emergency medicine. So my path was anything but typical, because I did these 2 gap years. And then after that, I went to a Caribbean island for 2 years, and then 2 years in the United States, which is crazy. Thinking about it now, I just basically threw all my chips in and said, I'm investing in myself, and this is what I want 100%. And I knew how much work it would take, and I did it. So that was my approach. Remember that your path is your path. Failure is normal. You're going to fail a lot in your career. I fail all the time, and that's how I learn, right? Let's take, for instance, I'm on anesthesia right now. When we intubate people, your first couple intubations, you're going to struggle, and it's going to be tough. But the more you practice, the more you learn from the mistakes you're making, the better you become. And now, I feel very proficient with airway management. And, with these failures, you learn from them, and then you grow into the person or doctor or dentist or, vet or whatever you want to be. You grow into that person. Okay. So what I'm going to do is a case. It's can be pretty advanced. So I'm not going to go into too much detail because there's a lot of anatomy and physiology. We're talking about the entire body, right? If a trauma comes in, advanced trauma life support, ATLS protocol suggests you do the primary and secondary surveys, which I'm going to talk about. So this is the case. You have a 35-year-old male brought in by EMS who reports status post motor vehicle collision around 75 miles per hour just prior to arrival. The patient was a restrained driver and was hit with direct frontal impact. Airbags were deployed. Patient has been intermittently mumbling and only responds to painful stimuli and is also unable to follow commands. He's vomited twice in the emergency department and doesn't seem to be protecting his airway and is gasping. Okay. So this guy comes in. Vital signs, temperature 99.2, heart rate of 120, blood pressure 90/60, respiratory rate of 24, and agonal, and oxygenation of 85. Normal oxygenation, guys, supposed to be over 92. We would like it above 95, but 92 technically is okay. Blood pressure, obviously, is supposed to be a little bit higher than that. And heart rate is too high. Normal heart rate is from 60 to 100, right? And temperature's okay. What do we do? What do we do in this situation? What you do when a trauma comes in is you take a deep breath and you think about your ABCs. So in ATLS, we're taught airway, breathing, circulation, disability, exposure, and adjuncts, right? So airway. Are they protecting their airway? Are they breathing through their airway? Is there blood or vomit in the airway? Do you need to clear something out? Can you intubate? Is there an indication for intubating this patient? Breathing. Listen to their lungs. Are there equal breath sounds? Is there breath sounds on one side but not on the other? When you tap on the on the chest wall, is there like a rib fracture you feel or any kind of deformity? Or maybe their chest wall is moving in a weird way. So that's the breathing part. Then you have circulation, which you're going to check all peripheral pulses, make sure everything's normal that way. The central pulses and the carotids. You're going to look for any signs of obvious hemorrhage outside of the body, external hemorrhage, as opposed to internal hemorrhage, which is bleeding inside the abdomen or chest or leg, which can happen with the bleeding into the leg that can happen with long bone fractures, like a femur fracture, which is the long bone in your leg, your thigh bone. And sometimes you can lose up to 1.5 liters of blood actually in your thigh bone, which is pretty interesting. And then disability. When you talk about disability, you're thinking about neurologic exam. Is this person neurologically intact? Are they acting like they are normally? When you do their neurological exams, is one pupil bigger than the other? Are they able to smile at you and have, symmetrical smile, or is one side down and the other side's up? Are they weak anywhere? Are they able to walk? There are so many questions you can ask. Then you have exposure and adjuncts. And adjuncts are basically like X-rays, ultrasound, but these kind of tests and blood tests, these kind of tests are done simultaneously with the primary survey. So right away, you're getting a chest X-ray, you're getting a pelvis X-ray, you're doing a fast exam, which I'll explain what that is. So that's the ABC of trauma, the primary survey. So airway. So this guy, because of his inability to breathe and his agonal respirations and mumbling, and he's just not with it, we're going to intubate him. You push your meds to intubate this guy. You have to paralyze and sedate them so they don't have their gag reflex. When you take this thing, it's called a laryngoscope, and you put it in their mouth and you lift up the epiglottis right here, and you insert a tube for breathing, which is this tube right here. It's an endotracheal tube. And this is a little bit of the anatomy here. At the same time, you're trying not to knock their teeth out, because that is a constant, medical legal thing that happens. But for the airway, you need to have your team assignments. You need to have your respiratory therapist there. You have to have, suction, oxygenation. You're going to have your airway equipment, your positioning of the patient's head, medications for induction, equipment, and backup airways. There's a ton of indications to intubate: respiratory failure, apnea, which means you're not able to breathe. GCS is the Glasgow Coma Scale, right? That's basically how with it a patient is. I'm not going to go into it. But anytime the score is less than 8, you intubate. That is a little tidbit of information. It's not always true, but that's just the general rule in emergency medicine. If you have a rapid change in mental status, like somebody is, let's say they hit their head, they passed out, they're up, they're walking, talking, they're completely fine. And then all of a sudden they rapidly deteriorate and their mental status goes completely bye-bye. That's an indication to intubate. Airway injury or impending compromise. So if somebody gets stabbed in the neck, like, you're not going to be able to pass a tube there. You're going to have to do a surgical airway. Airway injury in general, if you have, let's say, like a huge tongue laceration, or, maybe somebody got their teeth knocked in, and they're occluding the airway, you need to get in there, you need to suction it out and intubate. And sometimes you have to do, a surgical airway, which is where you have to make a cut here, find a little cricord notch here, and put a tube through their neck. And if a patient is high risk for aspiration, that's another reason. Aspiration means breathing in foreign particles like vomit or blood from their airway. And any trauma to the larynx. SOAP-ME is a mnemonic. I know it sounds weird, but it's basically a way for us to remember what to bring to the bedside and how to prepare for an intubation. You need suction, so you have a suction tube nearby just in case there's any bleeding or vomit that you need to suction up before putting the tube in. Oxygen, you're bagging these people with a pulse ox. Your airway, what kind of airway are you going to use? You're going to use an endotracheal tube, are you going to use bag valve mask, a laryngoscope, stylet, all these things. Positioning, how do you position the patient's head? Can you move the patient's head? Is their neck broken? I don't know. These are things you have to assess. And medications is the M, and equipment. And that's it. So that's airway in a nutshell, really quick, guys. Again, these are super advanced topics, and I'm trying to go through them as quick as possible. Next, breathing. So take a listen. And what do you hear? So the lung anatomy, you have right lung. You have 3 zones. You have the right upper lung, the right middle, and the right lower lobe. Left is left upper lobe and the left lower lobe, right? So there's 2 on the left and 3 lobes on the right. And what you do with this patient is you listen to their lungs on the right and you hear breath sounds after you intubated them and you're bagging them. And on the left, you actually don't hear any. So what are we thinking in this case? Well, I'm thinking that possibly this lung collapsed, right? And that's exactly what we see on this x-ray, right? So we actually see something very dangerous here. It's called a tension pneumothorax. Pneumothorax means there's air inside the lung that shouldn't, or air inside the thorax that shouldn't be there. And what it does is it compresses the lung and all of the mediastinal structures to the opposite side. So this right here is your trachea, which is the long tube down the midline right here that gets air into your lungs. And typically it's supposed to be right here. But there's so much air in this side, it's pushing everything this way, which is super dangerous. This can cause people to crash in a matter of minutes. And here's a little bit of a diagram to show what happens. So this is normal, obviously. You have your superior vena cava, the trachea right here leading to the right lung and the left lung, the heart right in the middle, and the inferior vena cava. So these two bring venous blood to the heart, which pumps it out to the rest of the body through the aorta. In cases of increased pressure in the pleural space like this, you're going to completely collapse this right lung. You're also going to collapse your SVC and your IVC. So there's no blood returning to the heart. So the heart is now like, what the heck? I have no blood to pump out to the rest of the body. And at the same time, the heart's being compressed. So your blood pressure drops, your heart rate goes up because it's freaking out. It's like, where I need more blood. I need to send it to the rest of the body, and the body needs oxygenation. And the left lung also gets compressed. And in our case, could be the tension pneumothorax is primarily caused by outside air getting in through a puncture wound. So in our case, let's just say that the guy who was driving, there was a shard of glass that went in and went under his rib and punctured that air. Okay, so this guy now, what do we do? He's crashing. So what we do is something called a needle thoracostomy. And what you do with the needle, it's a very long needle, probably about this long. And what it does is it's an emergent way to release the pressure of the air that is pressing up against everything. So you insert the needle here at the intercostal space and the second intercostal space at the midclavicular line. This is your clavicle. The midclavicular line is a line that goes from the middle of the clavicle down. Second intercostal space is the second rib space, which is right here. And that's that. Then you have the 4th to 5th intercostal space, mid-axillary line, right? So mid-axillary, your axilla is actually your armpit, and right in the middle is there. And then another space that you can put it is the anterior axillary line along the 4th or 5th intercostal space, which is just in front of that mid-axillary line. So once you do that, you hear a rush of air come out of the needle, right? So that means the pneumothorax is improving, right? Your patient's vital signs start to improve a little bit, but you're not done there. Now you have to put in a chest tube. The reason why you have to do this is because there's still a ton of air in there, and it's such a tiny tube. And if you guys remember something from physics, Poiseuille's law, the radius to the 4th power, right? As soon as you change that, your flow increases or decreases to the 4th power. So if you have such a tiny, tiny diameter and radius diameter of the needle, you should switch it to something a little bit with a little larger of a diameter. So in that case, you would insert a chest tube, and the chest tube's job is basically to drain the air that's collapsing that lung out, right? It could also be used to drain blood if there's a hemothorax, which is when there's bleeding inside the thorax, excuse me. Okay, C for circulation. So your A, B. So now this guy has he's been intubated, so he has a tube in his mouth. He has a chest tube now, and his vital signs are improving a little bit, okay? He's now put in a medical coma by us because we intubated him, and in order to do that, we have to give him medications to sedate and paralyze, right? And then we have to continue those medications afterwards because we don't want someone waking up and being like, oh my God, I have a tube in my throat. So next step is circulation, right? What are the pulses like? Is the skin perfused? Do they look gray? Do they look blue? Do they look pink? What do they look like? What's their level of consciousness? And do we need access? And again, that goes back to procedures like a central line, which is basically a catheter you put in the neck into the internal jugular vein. And that gives you access directly to the heart, where you can use medications to help increase blood pressure if the patient starts to tank again. And again, these are all the different access points. Whenever we have access, we always do venous access, and these are the main ones we do, which is the femoral right here, as well as the internal jugular vein, which is right here. Sometimes you do a PICC line up here. And if you ever need arterial blood gases, you can access arteries, but it is more high risk, but that is something we know how to do, right? Okay. And are there any signs of obvious external hemorrhage that you need to stop, right? Let's say this guy has an open fracture of his right lower extremity, right? Open fracture means there is, disruption of the skin over the bone, and the bone is fractured. We need to reduce that. We need to stop the hemorrhage by direct pressure. And in extreme cases, we could tourniquet it, which means you wrap a tourniquet around the leg to stop the bleeding. But that was just for argument's sake. Let's just say this guy's fine. He has no signs of external hemorrhage. Possible internal hemorrhage. I don't know. Let's do a fast exam with the ultrasound. Fast exam is a focused assessment with sonography, which is an ultrasound of trauma, right? So what you do is you put it over the belly, the heart, and, both kidneys and the bladder, and you're looking for any fluid outside in the abdominal cavity. And if you see fluid in the abdominal cavity that's not supposed to be there, that means there's bleeding or one of your hollow organs was ruptured and fluid has leaked out. And that's a surgical emergency. So in this case, we didn't see that, right? Again, there's no signs of internal hemorrhage either. And the pelvic x-ray was fine. There's no fractures. Chest x-ray just showed what I showed you before. So right now, all we have is the chest tube, intubation, and circulation is fine at this point. And as I said, long bones, you can fracture and lose up to about 1.5 liters of blood, which could lead to hemorrhagic shock, which that's a whole nother topic. So disability, which is D. So the rapid neurological exam, Glasgow Coma Scale, you're going to be looking at the patient and how they respond to your voice. Do they open your eyes when you talk to them? Are they already open? Do they open their eyes to painful stimuli? And then you look at, their motor or their vocal assessment. And you see, are they moving at all to painful stimuli? Like if I rub right here, do they localize it or do they go away from it? Do they do a certain posturing? There's all these things that we test, which Dr. Schuper will actually go into detail about the Glasgow Coma Scale tomorrow. So yes, Glasgow Coma Scale. Pupillary size and reaction, he'll also go into detail about that. It's It's basically looking at pupil size. Do they react to light? Is one much bigger than the other? This could show you signs of intracranial hypertension or intracranial pressure that's increased. We look at oxygenation, ventilation, and perfusion again, right? We're looking at their pulse ox. We're looking to see how good of a breath that they're taking every time on the machine. Are all those waveforms proper? Again, cap refill shows us perfusion, right? So when I press down on this and my hand turns white, actually, you guys can do that. Press down on your thumbnail, it turns white, but it goes right back to pink, right? And that shows you that you have good perfusion. That means you're adequately hydrated. If you have a cap refill, which is what that is, capillary refill, if you have greater than 3 seconds, then you may not have enough fluid. So that's a good way to check perfusion status as well. You can do really simple things like look at their blood sugar. Hypoglycemia, hypo meaning low, glycemia meaning sugar in the blood. And if you have low blood sugar, that's an easy fix. Do they have alcohol in their system? Because that's a CNS depressant, central nervous system depressant, or narcotics. I mean, we're in an opioid epidemic right now, and we see a ton of patients come in on heroin or opiates that have completely, thrown them for a loop. And whenever someone is not acting right, like this guy, he's mumbling, he's not really answering questions. We had to intubate him, right? Not acting right. So we always assume there's an injury with altered mental status in a patient. Because again, in the emergency department, we're thinking worst first. That's the most important thing. Worst first. And you frequently reassess their neurologic status. So as I talked about before, exposure, you have to actually take all the patient's clothes off, and you have to see if there's any obvious signs of injury anywhere. You have to flip them. You have to look on their back. Do they have obvious spinal fractures or anything sticking out of the skin, or do they have bruising over certain areas that could lead us to a certain diagnosis? And you can find out a lot just by taking the patient's clothes off. And I know it sounds silly, but these are things that need to be done, right? Once you do that, you have to put the warm blankets on, because a big scare in the emergency department is hypothermia for patients, especially in a trauma or hemorrhagic shock situation. Adjuncts, and in reality, these all happen at the same time. The primary survey happens the same time. Like all of these things happen at the same time, right? There's a team member for each thing. There's somebody at the head of the bed for the airway and breathing. Circulation's being checked everywhere. People are putting lines in. People are doing the ultrasound scan. Radiology techs come in, take the chest x-ray, the pelvis x-ray. Neurologic exam is done, and then the exposure is all done, right? You need the ECG, which is this thing right here. As we talked about before, it looks at your electrical activity in the heart. Pulse ox, check if you're saturating well. Put you on a monitor and check all your vital signs right here. ABG, which is an arterial blood gas, to see if you're acidotic, which means that you're not getting enough oxygen to your blood most of the time. Put a catheter in to assess if your kidneys are working. See what your urine output is. NG tube, the nasogastric tube, see if there's any kind of anything inside the stomach. You need to deflate the stomach. Sometimes these patients can put out a lot of vomit. And then, as I said before, the x-rays. EFAST, which is the FAST exam, the extended FAST exam, which again is out of the scope of this talk. Secondary survey. I'm not even going to go into this one, guys. It's every body part. You need to worry about the mechanism. And in our case, this was a frontal impact. Frontal impact shows these are things you have to worry about. Cervical spine fracture. Cervical is all the spinous processes in your neck, right? You have to worry about that. You have to worry about rib fractures, myocardial contusion, which is bruising of the heart or blood inside the heart. Pneumothorax, which is what we've seen, which is we had a tension pneumothorax. Aortic disruption, aorta is the giant vessel off the heart. Sometimes at high enough shearing speeds, like our guy, 75 miles per hour, you get some shearing there and you can have disruption of the aorta. Also fractured liver or spleen, posterior fracture dislocation of hip or knee, or a head injury, facial fractures. Head injury, in our case, we're going to start head to toe. Head, maxillofacial structure, cervical spine and neck, as I said, the chest, abdomen, pelvis, musculoskeletal system, neurologic system, and then do your adjuncts, right? So once you've examined all of these things, you need to get your CTs. And the first thing we're going to do is get a CT of the head, and then the rest of those. But the first is the head. And this is what we see. So right here, this is called a subdural hematoma. And sub means underneath, the dura, which is it's a covering over the brain. It's a protective covering over the brain. And you get shearing of the veins underneath, and that can cause bleeding, compressing the brain. And sometimes you see this midline right here shift, which is a bad sign. And in this case, this is what we see. We're starting to go towards that route. And now we know why our patient was a little bit altered. Definitive care, in the emergency department, we stabilize, we resuscitate, and we send them to the next person, right? Call your consultants. And we found there's a brain bleed, right? After we did all those other things, right? Who are you going to call? I'll tell you who you're going to call. You're going to call Dr. Schuper and the neurosurgery team. And Dr. Schuper and I have been talking about this, and he wants to continue this case tomorrow. So he's going to talk to you about intraoperative management of this subdural hematoma and the anatomy and physiology that goes along with it. So, is emergency medicine the right fit? When you walk through the doors of your emergency department, do you get an overwhelming feeling that you belong there? Does the thought of a trauma or code where you can save a life give you a surge of adrenaline and excitement? I don't know. That's up to you guys. When you see a stranger who is injured, do you run to them? Do you enjoy the diagnostic inquiry of undifferentiated illness? And do you enjoy a wide range of clinical challenges requiring a variety of skills each shift? Do you enjoy the fast-paced work environment? So remember, emergency medicine's dynamic, it's exhilarating, and it's ever-changing. You have to think about best fit. You got to think about yourself. Who are you? Do you have strong interpersonal skills? Do you have a calm demeanor? Do you desire to work as a part of a team? And in order to be a successful emergency physician, you have to be kind, hardworking, and very flexible. The interpersonal skills is huge for this. So with that, I'm going to leave you guys this advice. If you are willing to invest everything you have to get to where you want to be, you will get there. Remember, you are your own investment. And that's my best advice to you guys out there, because I know a lot of you are anxious about getting into medical school right away, but realize a year or two is a gap year to strengthen your application or to mature and add things to your application that will differentiate you. Can be extremely helpful and very rewarding. So thank you for attending. And this is my Instagram. If you guys want to follow me or have any questions, you can DM me your questions. And this is my podcast that me and Dr. Schuper started a while ago. We have quite a few episodes up now. It's called the Res Life Podcast. It's on Apple Podcasts if you guys want to check it out, where we do a bunch of episodes on random medical topics for pre-meds, med students, residents. And we actually just started a So You Want to Be series where, I started the first episode by asking Dr. Schuper, who's a neurosurgeon, about how he got into that, what he did to get to where he is, advice he has for people who are trying to do it. And then the next one we do is going to be with me for emergency medicine. We're going to do all the different types of specialties too. So that's exciting. All right. So I'm going to open up the floor to some questions. I know there's a ton of questions on the stream. I saw, Yeah, I thought the cliffhanger was a good idea. I really, I don't know, I came up with that the other night when I was talking. Do you know how many times I've seen this on Grey's Anatomy? That's funny. So when doing a needle thoracostomy, is there a risk of puncturing the lung? So what you're doing is you're assuming that there is a pneumothorax. So you're not going to puncture the lung. You're just puncturing the pleura, which is the covering around your lungs, right? Mm-hmm. All right. Hey, Nicole, are there any like questions that you guys saw that need to be addressed?
Yeah, the questions are coming in through right now.
Okay. Is there a chat thing?
It's in the YouTube comments, but I can copy and paste them in the Zoom chat if you'd like.
Hold on 1 second. Okay. Let me just check in the Zoom or in the YouTube. No problem, everybody. I'm glad you enjoyed it. I'm sorry again. I really tried to rush through everything because, primary survey, you could talk about airway. You could talk about that for, 3 hours because there's so many things to talk about. And breathing, same thing, like tension pneumothorax, the pathophysiology. You could literally talk all day about that. So there's a lot of different things. So my experience with Caribbean med school. So this is a question that I get actually a lot. And, there's a lot of stigma towards Caribbean medical schools. Everybody who's pre-med is a perfectionist and everybody wants to go to Harvard. And, I just want you guys to realize, like, even some of the best candidates don't get interviews or, where they should be getting interviews. And even some of the best candidates end up at okay med schools. But the problem is that there's no such thing as an okay med school. All med schools teach you the same thing, right? If you want to get more into research kind of stuff and you've done a ton of publications in college and that is what you want, then yeah, shoot for the more academic centers. But med school is med school is med school. I believe the Caribbean, St. George's actually put a huge chip on my shoulder because I had to work that much harder than US students to actually get into a residency program because there is that against me, right? I had to score much better on my boards than the average US med student getting into emergency medicine. I had to, be a part of all these different societies and get involved in, different programs like the Emergency Medicine Residency Association, EMRA. I got involved in their leadership academy. There's a lot of different things you can do as a Caribbean student. It's just how hard do you want to work and how bad do you want it? And as I said before, the quote, you are your own investment. So if you really want it that bad and you are 100% committed, just realize you're investing in yourself, right? And nobody else can make that decision but you. And you need to be willing to work that hard to get that residency spot. And I have a ton of friends. Actually, St. George's was the #1 provider of residency residents this past cycle, over 1,000, which was kind of crazy because we have a ton of students. But I had a lot of great classmates who were brilliant. And I would say over half my class probably should have been in US med schools. So with Caribbean, it was 2 years down there and amazing island. I had such a great time down there. After exams, honestly, med school is, it sucks regardless because you're studying all the time. But after exams, it was always so much fun. And that's it. Being a trauma surgeon follow. So actually there is a difference between trauma surgery and emergency medicine. So emergency medicine is 3 years. Surgery, trauma surgery is 5 years of general surgery. And then I believe 2 or 3 years of trauma. So that's a long path. And what you do is let's say, like when I was talking about internal bleeding versus external bleeding, if you find on a ultrasound scan that there is free fluid in the abdomen and you're like, okay, this person's bleeding into their belly, they go right to the operating room and the trauma surgeon does that operation. They stop the bleeding. And a lot of them deal with surgical ICU, intensive care unit as well. So trauma surgeon is extremely different from emergency medicine, but we work together as a team, especially when the traumas come in right away. Physician assistants are great. They're a great adjunct to the emergency department. A lot of them see triage patients. They'll do laceration repairs. They do I don't want to say the less intense stuff, but that's what they're there for in the emergency department. They help us big time. I know one of the biggest benefits for being a PA is that you can switch specialties whenever you want. Whereas medicine, this is your specialty for the rest of your career. And that's a huge benefit to being a PA. But I don't have too much advice on that. Say you take a gap year after your undergrad and just before you go to med school, is it wise to do so? So if you're going to take a gap year, I advise doing something medically related, whether it's research, whether it's a master's program, or whether it's scribing. Scribing was an incredible experience. I learned so much before starting medical school, and I think it really gave me a huge advantage over other medical students that were first years, because the medical language barrier is huge. And being a scribe, I heard all of those things, and I, learned a lot of treatments, medications. I even learned about EKGs when I was a scribe. So there's a huge advantage to that if you're looking for something medically related. I only applied to SGU too. I did not apply anywhere else. And that was because a family friend, that physician was an emergency physician who went to SGU. And I didn't really look into anything else. Yeah, the pleura does regenerate in that case. So again, I went to a Caribbean school because I did not get into a US medical school, right? So I applied twice, didn't get in. I said, you know what, I'm going to just go for it. And I did full send and went to the Caribbean. And now I'm a doctor in the United States, which is pretty cool. And I'm doing the same kind of training that every other US MD or DO is doing, which is great. So again, tension pneumothorax, I could talk about that pathophysiology all day. So a question, why did the left lung shrink when the pleural space was punctured? So what happens is when you introduce the puncture wound to the pleura, you are introducing a higher pressure from the outside versus the pressure that was in the pleura. So when you have that higher pressure going to a lower pressure, it's going to shrink the whole thing. And that's basically how that happens. I mean, that's a very, very simplified way of putting it, but it's a lot about pressure differences in the pleura versus the lung versus the alveoli versus atmospheric pressure. If you guys could get a master's, that's fantastic. That looks great. I mean, I've met a lot of doctors too who were in training that actually were lawyers beforehand. A lot of them had second careers. I actually had a couple people in their 40s and 50s in my class, which was kind of crazy. All right, let's see if I can find a couple more. Yeah, so the clinical management would be the same for hemothorax versus pneumothorax. So hemothorax, as soon as you see blood coming out of the chest tube, there's a certain cutoff for that amount of blood. If you have, I forget the exact cutoff, it's like over a liter drained, or I forget, it's like 250 cc's per hour or every 2 hours or something like that. There's a certain threshold where you go, okay, this person needs to go to cardiothoracic surgeon now, or the trauma surgeon will be like, this guy's going to the OR. We're going to clamp the aorta and find where the bleeding is so we can stop it. So that goes to the OR, the hemothorax. There are no prerequisites to become a scribe. You go through employee training and medical terminology training. So I got my master's in 1 year, and then so that was after I graduated from Hopkins. I got my master's at Drexel, which was 1 year, and then I scribed for a year, and then went to St. George's. So NPs and PAs practicing independently, that's a really controversial topic. In emergency medicine, that would never happen. And so they're trying to make that more of a family medicine thing, and I'm not really sure how that's going to happen. That's a huge topic too. So my scribe program actually changed. It used to be MCare, then they got bought out by Envision. There's all these different types that you can look up on Google. I got paid $15 an hour actually when I was a scribe. I would try to get more scribing in. So MCAT, I mean, I got on the old one, I got a 30, which was average. And then I got a 505 or something. I forget. And it still wasn't good enough, right? But the MCAT at the end of the day has no medical correlation at all. It's just a standardized test to try to, rank people. That's the whole point of the MCAT. I really don't see a point. There is no clinical correlation or correlation. Because I know kids that did really well in the MCAT and then they failed their boards or did not do well on their boards. And in my case, I did very well on both of my boards. And that's a big reason why I matched into emergency medicine. Nicole, did you see any recurring themes with questions or anything that, you would want to ask before we're finishing up?
Someone asked what's the most common diagnosis that you often see?
So again, in the emergency department, you see so many different complaints. I believe the number one complaint is abdominal pain. And a lot of times we don't really have an explanation for patients. Their labs will be normal. Their CAT scan will be normal. And there's really not much we can do for them at that point. Then we recommend follow-up with their primary care doctor. Other times we'll have shortness of breath. You have someone with like COPD or emphysema that comes in, or asthma, and they're short of breath, and you have to treat them with bronchodilators and medications, steroids, that kind of stuff. So those are two pretty common ones in the emergency department. Right now, obviously, we're seeing a lot of COVID. I'm down in Florida. So right when I started my residency, we started like right when COVID was huge down here. And I saw a lot of people code. I saw a lot of people get intubated and sent upstairs. And a lot of people don't do well with that. So that was really an interesting start to my residency for sure.
Thank you so much, Dr. Reilly. This was a wonderful and informative presentation. We all learned so much from you. And thank you for answering all of our questions.
Yeah, I tried the best I could. So I appreciate everybody coming out. And if you guys have any questions, you can follow me on Instagram at Doc Riles, DocReilles. And then you can just DM me and I'll get to you when I can. Again, I am a resident, so I'm very busy, but I will try to get back to you as soon as possible.
Everyone, make sure to check out his socials and his podcast.
Yeah, the podcast. And then you guys are in for a treat with Dr. Schuper tomorrow. He's amazing. Awesome dude and very down to earth for a neurosurgeon. Exactly what you would not be expecting to see in a neurosurgeon, that's for sure. So tune in for that tomorrow.
Yeah, we're looking forward to it.
Yeah, for the
And,
continued case.
and additionally, thank you all for attending. The link to the Google form has now been posted in the chat, and it is now in the description of this video. Please fill it out within the next 30 minutes for us to receive verification of your attendance. And again, thank you so much, Dr. Reilly.
Yeah, of course. It was my pleasure. I'm glad everybody actually enjoyed it.
Thank you.
See ya.
Have a good day.
Thanks. Hey, Nicole, thanks for having me on, by the way. This was great.
Thank you so much for presenting and taking time out of your day to do so.
Yeah, that was it was difficult coming up with this PowerPoint because again, there's so much that can go into it, but I feel like trauma is that sexy topic that everybody likes to hear about. So I tried to do that as best I could. So
thank you.
All right. And I'll see you later.
Thank you.
Yep.
We're having difficulties ending the live stream because Aaron's computer is glitching right now, so I don't have access to, but if you want, you can leave.
All right. I'll see you later.
No,
Thanks.
I don't know how. Thank you. Bye.